Thank you, Mr. Chair. And I love, and thank you, Mr. Topping, I love hearing that you want to pay for the highest quality care veterans can receive. I think we all want that. I would like to ask first, which healthcare organizations in the U.S., either government, nonprofit, or for-profit, have utilized this indefinite delivery, indefinite quantity IDIQ contract structure you are proposing?
Representative, VA uses IDIQs and uses them in multiple areas and multiple spaces. This is the first time for a healthcare contract that VA is using this. This is used outside of our agency and other parts of government as well too. The IDIQ is a vehicle which allows the government to buy services if it doesn't know up front exactly what it needs and when, but can pick a stable of vendors that we know are capable of delivering that. That's the use of the IDIQ. The model of an IDIQ is not new to VA, not new to government.
And I do want to get through a lot of questions, so I appreciate that, but I think I understand it's not new, but I think that we all have concerns with some of those well-vetted vendors that there have been misuse of federal dollars that should have been taking care of veterans and may have been misbilled, let's say. So for our committee to do effective oversight, I would like to see a list after this hearing of those entities and any market research VA has conducted on those organizations that we are considering using this contract. And based on your testimony, it seems contractors alone will propose and pilot alternative payment models to test on the veteran population. How does the VA plan to evaluate these care models, especially related to quality outcomes when they are being offered outside the direct care system?
VA will make the determination on which models we use. So VA will drive this, VA will make the ultimate decision. What we do want to do, and again, this goes back to the IDIQ vehicle, is we want different vendors with different capabilities, and they'll be regional, we understand that. We want these vendor partners to come in and make proposals based on what they have used and what has been successful in their network, in their areas. Those will be different in different parts of the country. What we're gonna be able to do in terms of value-based care in the upper Midwest, largely rural, where you've got potentially limited providers versus what we could do in Metro DC, very different. That's why we want them to bring the proposals, but we will make the decision.
And I appreciate that, and I think it all sounds fantastic, but really putting it into practice has been extraordinarily difficult. I come from a healthcare organization, I know this very well, and I just want to use as an example, my team sent a letter to Secretary Collins on September 22nd asking for what was required by Congress in December 2022 for the VA to develop a plan to ensure veterans are informed of expected wait times at VAs and in the community. That was over 3 years ago. We asked for that information, and our team has been reminding folks weekly since September that we are waiting for that information and still have not gotten an answer to that. I find it hard to believe that we are still waiting for just how long does it take for a veteran to get an appointment in the community over 3 years from when Congress said it should be so, that we actually have the capacity to have appropriate oversight and transparency for outcomes for our veterans if we can't even tell when they are getting appointments. I would love your response to that.
Representative, let me take that. I haven't seen the letter. I'm not aware of the ask. Let me take that and come back to you.
Mr. Chair, if I may ask to submit into the record the letter dated September 22nd, 2025. It'll be available for all. I also want to just...
Without objection.
Thank you, sir. I appreciate that. You noted in your testimony also that the VA will implement comprehensive quality programs for community providers based on nationally recognized measures that will, quote, ensure veterans are not simply referred to any available provider, but to those demonstrating strong outcomes and safe, high-quality care. Again, I share this goal. However, given that vertically integrated healthcare entities often restrict patient visits to their own providers, how can you clarify any guardrails that will be in place to ensure that veterans in the community care programs will be referred to providers with highest quality outcomes rather than just those preferred by any contractor?
Representative, number one, we're using healthcare research and quality data. You've seen and you've worked with those. HEDIS, you've seen and you've worked with those. These are well-known, well-understood by both payers and providers. We are using the metrics that the industry understands. We're going to measure to those. Where we set the goals and the outcomes and the requirements, VA will determine that. But all of that is to say, too, and I think probably this is the fourth time I've said it here today, too, The plans will not determine where the veteran goes. We will make the referral. We will determine where the veteran receives the care. And we want our veterans to go to those providers that can provide the highest quality at the lowest cost. The intent of this program and the tools that we have built into it enable us to do that.
So I'll follow up on that because I worry that in the actual delivery systems, the VA is not going to have the level of engagement to actually be able to direct those visits. We know that those vertically integrated systems are already shunting lower paying patients to different outcomes. So I am concerned that you actually can deliver on that and would love to understand some details on that and follow up. Thank you, Mr. Chair. I apologize and we yield back.